My name is Vicente Torres. I am a nephrologist at the Mayo Clinic with a long interest on polycystic kidney disease. In my talk, I'm going to discuss the value of total kidney volume and other imaging biomarkers, and review the studies that are outlined, that are shown in this outline. In an old study from 1955, with a study of 366 cases of polycystic kidney disease at the Mayo Clinic, the authors indicated that it should be possible to prognosticate accurately in polycystic kidney disease. But they were careful to indicate that the behavior of polycystic kidney disease is often unpredictable, and that any prognosis must be given cautiously and accepted with some reservation. And the reason why the polycystic kidney disease was thought to be unpredictable is because during decades the kidney function remains within the normal range, only to start decreasing at an advanced stage and then decreasing quite rapidly. Franz and Royby were the first investigators to develop a mathematical model for the progression of polycystic kidney disease. In this model, the radius of the cyst increased at a constant rate, and the residual volume, parenchyma volume, decreased at a rate that was proportional at the rate of increase in the cyst volume. When discussing this model, however, the authors were careful to indicate that the total kidney volume does not always provide reliable information, since it includes both the cyst and the tissue, and admitted that superimposed pyelonephritis and hypertension may play a contributory role. This model, or the validity of this model, was somewhat confirmed by a longitudinal 8-year study of CT scans in 9 patients with polycystic kidney disease. Since the total kidney volume and the total cyst volume correlated positive with age and negatively with baseline GFR or the slope of GFR, whereas the contrary was true for the non-cystic or parenchyma volume. In this study also was observed that the total non-cystic volume, the total parenchyma volume, was larger than the volume of 2 normal kidneys. Most of what we know currently about the natural history of polycystic kidney disease derives from a prospective study, the CRISP study, which is a longitudinal study of 241 patients, relatively young and with preserved kidney function, but 2/3 of them at high risk for progression. This study has been ongoing for 20 years in 4 periods of 5 years, which are known as CRISP 1, 2, 3, and 4. During the study, many GFR both measured and estimated, as well as total kidney volume measures by MRI using histology were obtained. The main results of CRISP-1 confirm that the non-cystic volume was larger than the the normal parenchyma volume of 2 normal kidneys. That the rate of kidney growth was quite different from patient to patient, quasi-exponential, and was unique and constant for each patient. And the same was for the cyst volume. And there was a tight correlation between the total kidney volume and the total cyst volume. The correlation between the increase in total kidney volume and decline in GFR in the CRISP-1 study was weak, but highly statistically significant. And the decline in GFR was observed only in patients with a baseline total kidney volume of over 1,500 mLs. because the measurements of total kidney volume were more accurate and reproducible than those of total cyst volume, and because the information obtained from total kidney volume and total cyst volume was very highly correlated, cyst volumes were not measured during the remaining CRISP studies. Another important observation from CRISP-1 was that the total kidney volume of patients with PKD1 mutations in red were higher than those of patients with PKD2 mutations in blue. However, the rate of increase in total kidney volume was not significantly different between the two groups of patients. And the reason for the total kidney volume being higher in the PKD1 mutations is because patients with PKD1 have many more cysts than patients with PKD2. The main results of a PKD of the CRISP-2 study will be shown in this slide. And in PKD2, the total kidney volume was adjusted for height in order to reduce or eliminate the differences that are related to body size or gender. While the GFR in red remained constant during the CRISP-1, in CRISP-2 started to decline. And the poor correlation between total kidney volume and GFR, which was created artificially by the entry criteria of the CRISP study, this weak correlation in year 1 became increasingly stronger during the following years as the as the GFR started declining. And the total kidney volume in this analysis was shown to be a good predictor of reaching CKD stage 3 with good sensitivity and specificity. Now, this prognostic information derived from measuring total kidney volume was difficult to translate into clinical practice because of a number of challenges. First, the kidney volumes as measured in CRISP are very time-consuming and costly. Second, the total kidney volume and GFR decline were not always correlated, and there were exceptions. And third, the prognostic value of height-adjusted total kidney volume varies with patient age. To address the first challenge, the ellipsoid equation to measure total kidney volume was validated against the gold standard. To address the second challenge, atypical criteria were developed to exclude atypical cases or class 2 ADPKD patients. And these included patients that had unilateral, asymmetric, segmental, or lopsided distribution of the cyst, as well as patients that had evidence of ischemic changes due to vascular disease. The fact that the exclusion of atypical cases was validated by the fact that age and height-adjusted TKV interacting with time from the baseline values was statistically significant in the class 1 typical patients, but not in the class 2 atypical patients. To address the third challenge, that the prognostic value of total kidney volume varies with patient age, a classification integrating total kidney volume and age to estimate the rate of growth of the kidneys, assuming an initial common kidney volume was developed. And patients were stratified in 5 classes from low rate of kidney growth in class A to the highest rate of kidney growth in class E. Again, this classification was validated by showing that age and kidney volume interacting with total kidney volume could be replaced in a different model by the classification. And the image classification was shown to predict the GFR slope, as well as the risk of developing end-stage kidney disease, as well as the mean age at the time of development of the kidney failure. And an equation derived from these mixed models was able to predict with a good expected predicted error future GFR and both in the internal and external validation cohorts using the image classification, gender, age, estimated GFR, total kidney volumes, and years from total kidney volume. There is an app available on the web that facilitates the measurement of total kidney volume using the ellipsoid equation, as well as estimating or calculating the image class. Now, this image classification could be used for prognostic enrichment, and to determine whether that was true, a post-hoc analysis of the HALT-PKD study was performed. In this study, rigorous blood pressure control was accompanied by a significant reduction in the rate of growth of kidney volume, but there was no significant effect on the rate of eGFR decline. By stratifying the patients in three groups, one with low progressors, intermediate progressors, and rapid progressors, the rigorous blood pressure control also resulted in a significant effect by reducing the rate of eGFR decline, showing that it's very likely that image classification was going to be able to be used as a prognostic enrichment method. Now, the PKD, the Polycystic Kidney Disease Outcomes Consortium, was formed by the regulatory agencies, the PKD Foundation, academic centers, and pharma, trying to qualify the total kidney volume as a prognostic biomarker. For this, information from different sources, University of Colorado, the CRISPR study, Emory, and Mayo, was compiled. And this included 2,355 patients who had total kidney volume data and up to 30 years of follow-up. The polycystic, in these studies, the baseline total kidney volume, baseline age, baseline eGFR, and the interaction of total kidney volume and age and eGFR in baseline, and eGFR and age, was able to predict the risk of 30% decline in GFR, as well as the risk of reaching end-stage kidney disease at high levels of significance. And the hazard ratio for developing either 30% decline in GFR or end-stage kidney disease was much higher in the patients that had a higher kidney volume, both for eGFR decline and for end-stage kidney disease. And there was an interactive tool created to compute the hazard ratio for end-stage kidney disease or 30% decline in eGFR, which is available on the web. In addition, a joint modeling was used to assess the effect of longitudinal time-varying total kidney volume on the time to 30% eGFR decline or end-stage kidney disease, and was found that the total kidney volume intersect the growth rate the total kidney volume at the time of the event, either 30% decline in GFR or interstage kidney disease, and the baseline GFR, all significantly predicted 30% GFR in decline in GFR and end-stage kidney disease. And the observed probabilities of avoiding 30% eGFR decline or end-stage kidney disease were well within the 95% confidence intervals of the predicted probabilities, validating the model. Based on these studies, the FDA and the EMA qualified total kidney volume together with age and eGFR at baseline as a prognostic biomarker to identify patients likely to experience progressive eGFR decline or progression to end-stage kidney disease. Now, the CRISP-3 provided a longer follow-up, 14 years of follow-up, allowing a prospective ascertainment of the predictive value of total kidney volume for advanced CKD stages, and also allowing the modeling of long-term eGFR trajectories over the adult lifetime of ADPKD patients. So by 12 years of follow-up in CRISP-3, there was 40% of the patients had declined the kidney function by equal or over 57%. 70% had experienced a decline of 30% or more, and about 40% of approximately 30% of the patients had reached CKD stage 4 or end-stage kidney disease. Like in CRISP-2, the correlation between baseline HTKV and GFR follow-up increased with time, and the correlation between the change in GFR and the change in high adjusted total kidney volume was better than it had been observed in CRISP-1, showing again increasing improvement of the correlation between changes in GFR and changes in total kidney volume as more and more patients start having a decline in GFR. Both on an adjusted model or an adjusted model for age, sex, race, body mass index, and baseline GFR, total kidney volume predicted advanced CKD endpoints, stage CKD 3, stage CKD 4, and stage 5, as well as 30% reduction in GFR or 57% reduction in GFR. Now, genotype was significant also in a multivariate model, but only when the height-adjusted total kidney volume was not included in the model. When height-adjusted kidney volume was included in the volume, the genotype was not a significant predictor. The second main contribution of CRISP-3 was a better understanding of the GFR trajectories. This slide, you have the trajectories of total kidney volume showing increase in total kidney volume in most patients, but very variable from patient to patient, whereas the trajectories of GFR appear to be all over the place. However, stratifying the patients by the rate of growth of kidney volume to the 5 groups, the trajectories of GFR became much better, showing curvilinear trajectories and starting with a fast decline, starting faster and being more rapid in Class C, Class D, and especially Class E. Polynomial model was developed based on this to fit these observations, and this polynomial model that was developed for CRISP was validated in the HALT-PKD study A. more recent study in 2021 from the Mayo has studied the relative value of genotypic and imaging information to predict the functional decline in polycystic kidney disease. This study included 1,079 patients from Mayo and 832 patients from the CRISP and HALT-PKD study. The patients from Mayo were slightly older and had higher TKV and lower GFR than the patients in CRISP and HALT, but other characteristics were similar. The height-adjusted TKV, the image classification predicted both the genotype and image classification predicted renal survival, but the discriminatory power of the image classification was better than the discriminatory power of genotype. Both genotype and image classification predicted time to end-stage renal disease and time to a 50% reduction in GFR. But again, the image classification had more discriminatory power than the genotype. In the multivariate analysis, both the Mayo image classification and the genotype were significant independent predictors of GFR decline, together with baseline GFR and borderline effect of body mass index. And concordance indices and other values were also studied. And for the mix, for the image classification, the concordance index improved adding other baseline parameters or adding genotype, and with improve with everything in the model. Whereas genotype unadjusted, the concordance index was lower than in the concordance index of the image classification, and was also enhanced by adding other baseline parameters. And the same observations were seen using prediction to 50% decline of GFR, with image classification having a slightly better concordance index than the genotype classification. And the trajectories by image class, again, were similar to those observed in the CRISP study and were validated also by the CRISP and HALT studies. Another study from Mayo focused on the characteristics of patients with end-stage kidney disease, and particularly on the kidney volume at end-stage kidney disease. The hypothesis was that if kidney volume and cystic expansion was the only or the most predominant factor in determining progression to end-stage kidney disease, all the patients who had pretty similar end-stage kidney volume at end-stage kidney disease, which that was not the case. In fact, there was a slightly negative correlation between age and total kidney volume at end-stage kidney disease. Classifying the patients according to the image classification, we can see that the patients with the more severe disease reach end-stage kidney failure at a younger age and having a higher cystic volume, and progressing from the more severe kidney disease in class D to class B. You can see that the patients reach end-stage kidney disease at an older age and with lower kidney volumes, suggesting that with aging, other factors in addition to cystic expansion may play a role. And this is shown also in this table, showing the mean kidney volumes in patients with class 1E compared to 1B, the mean age, compare younger patients in 1E compared to 1B. Now, there was a majority of patients being male patients in class 1E, indicating that males has more rapid cystic expansion, and patients with severe mutations also predominant were predominant in class 1A, whereas in patients in class 1B, there was a predominance of females, and also there were more frequent weak mutations. These what additional factors play a role in the progression to polycystic to end-stage kidney disease in polycystic kidney patients remains to be determined. However, vascular remodeling and rarefaction that were proposed to play a role many years ago are likely candidates. So we propose that in patients with polycystic kidney disease, cystic burden and cystic expansion plays a significant and very major role at early ages, whereas in older patients with a more predominantly women, aging and vascular remodeling play a significant role. And this slide kind of shows a typical evolution of a patient with a class 1E patient that has higher kidney volume at baseline, including not only higher cystic volume, but also higher parenchyma, which is represented by between the kidney volume and cyst volume, and then have a rapid decline on the cystic parenchyma over time, compared to patients with mild disease, where there is less increase in kidney volume and a more slow progression of the disease. And it is likely that in this non-cystic parenchyma, there is a lot of untapped information that in the future will be available with new imaging techniques. For these advanced imaging techniques, it's important to segment the kidneys. This is not done by stereology, it's done by planimetry. So methods to segment the kidney had to be developed. And first, there were a number of semi-automated methods that were developed, but in the last year or two, several groups have developed deep learning-based, fully automated segmentation, which will become increasingly available and allows segmentation not only of kidney volume, but segmentation of individual cysts and cyst volume. So this is an example of automated total kidney volume segmentation, indicating that the error in reference to the standard segmentation is quite low. Now, in addition to total kidney volume, there are other features that are present in the images that are important to consider. So it is obvious that total kidney volume sometimes is not an accurate way of an accurate prognostic indicator. So for example, 900 cysts of 1 ml each produce much more damage than 3 cysts of 300 ml volume each. So the same kidney volume, but different number of cysts, different cyst parenchyma surface area, different cyst composition, and different secondary events such inflammation and fibrosis are important and could be abstracted from images of the kidneys. One way to abstract this information is using texture analysis, using different texture features. And texture integrates information from both cystic and non-cystic tissue. And a recent study by Tim Klein showed that adding texture analysis to the classical baseline prognostic indicators of age, EGFR, and total kidney volume adds significant prognostic value. Problem with texture analysis is that different features provide different values, and it's difficult to integrate all the features together. That shows again the improvement in the correlation between the prognostic indicators and the change in GFR when the texture is added to the typical or to the more classical prognostic indicators. Another important information is cyst count. And cyst count can be now obtained with fully automated segmentation, and in addition allows characterization of different types of cysts. This is the methodology that is used that I really don't understand, so I skip the slide. And this just as a representation comparing the segmentation by manual segmentation and automated segmentation in patients with milder or more severe renal cystic disease. And a good correlation that exists between the automated segmentation and human manual segmentation for cyst volume, cyst index, and cyst number. So in summary, at the present, total kidney volume is the strongest validated predictor of GFR decline in ADPKD. Height-adjusted TKV, together with age and GFR, or derived model like the Mayo Image Classification, are useful for population selection and prognostic enrichment in clinical trials. Fully automated methods to measure total kidney volume will likely become increasingly available and facilitate the utilization of total kidney volume in clinical trials and practice. At an individual level, height-adjusted total kidney volume together with age and eGFR is a moderately good predictor, but improved deep learning-based tools can capture and tap imaging information which will improve the predictive value of height-adjusted TKV. And as the predictive accuracy of TKV enhanced by other images biomarkers increases, its validation as a surrogate endpoint should be considered. And that's it. Thank you for your attention.